Before we start, a reminder that Lucy Letby faces 22 charges, 7 of murder and 15 of attempted murder. She has entered not guilty pleas to all charges. The cause of death was given by the coroner as hypoxic ischemic damage of brain and chronic lung due to extreme prematurity. All loops of bowel showed significantly dilated lumen due to increased air content. In layman's terms, they were expanded like a partially inflated balloon. There was no signs of NEC or any other bowel problem. The prosecution say there were signs of earlier hypoxic ischemic damage. In other words, the earlier attempts to kill her had caused brain damage resulting from a shortage of oxygen. Medical expert Dr. Evans said he believed the apnea monitor might have been switched off on October the 13th for child I, and the deliberate administering of a large bolus of air into child I's stomach via her NG tube on October the 22nd or 23rd. In police interview, Letby said she could not remember the circumstances of September the 30th and had taken over the care of child I after the child had a quote episode. She said she had no recollection of the events surrounding child I's death and said the child had been returned from Arrow Park Hospital too quickly. In June 2019, she was asked about a sympathy card she had sent to the child's parents. She said it was not normal to do so, and this was the only time she had done it. She accepted having an image of that card on her phone. She was asked about the October 13th incident and challenged the nurse's account, adding, quote, "Maybe I spotted something that the nurse wasn't able to spot," end quote, as she was, quote, "more experienced." She was asked why she had searched for the parents' details on Facebook. She said she did not recall doing it. The prosecution say child I was doing well by the time Lucy Letby got her hands on her. Quote, "What happened followed the pattern of what happened to others before and what has yet to happen to others. All of a sudden, out of nowhere came vomiting, breathing problems and critical desaturations. It was persistent, it was calculated, it was cold-blooded." Child J attempted murder charge. Child J, a girl, was initially stable, but it was discovered she had a necrotic and perforated bowel. She was transferred to Alderhay for surgery to fit her with a stoma bag. Child J, quote, "recovered well" and was taken to the Countess of Chester Hospital on November the 10th, 2015. She had a relatively rare type of intravenous line fitted, a quote, Broviac line. On November the 16th, medical notes refer to her as being well. But on November the 27th, she suffered an unexplained collapse in the early hours. Letby was on duty. Before she went to work for that shift, Lucy Letby exchanged text messages with one of her colleagues. The prosecution say it seemed that she was not happy with working conditions, and she referred to the difficulties of looking after the babies who just needed feeding support. Child J was one of those. The prosecution added that it appeared working in such nurseries was, quote, "not sufficiently stimulating for Lucy Letby." Letby was in a different room to Child J and was not the designated nurse, but, quote, "got involved by co-signing for medication at 12:02 a.m. Letby's colleague was a Band 4 nurse and not sufficiently qualified to give intravenous medication. After 4:40 a.m, that nurse thought Child J became pale and mottled. She left the room for a short time, and upon her return another nurse was assisting Child J with breathing. The last thing Letby had recorded on notes was at 3 a.m. There is data from the door system showing Letby coming in at 3:47 a.m. The prosecution suggests Letby had been on a break during that time. Just after 5 a.m, Child J suffered another desaturation, and she was moved to the high dependency unit in room 2. The registrar was called and Child J was working hard to breathe but had otherwise recovered well. At 6:56 a.m, Child J's alarm sounded and Letby was among those responding. A doctor attended and took control. He noted oxygen levels were, quote, "unrecordable and circulation poor." There were symptoms of a seizure. At 7:20 a.m, Letby co-signed a chart for a 10% glucose infusion. At 7:24 a.m, Child J collapsed again. The doctor assisted in resuscitating her. Child J recovered and the doctor could not explain what happened from the results of various tests taken. He considered the events unexplained. Medical expert Dr. Evans described the collapse at 7:11 a.m. as unexpected without any straightforward explanation. He said that it was, quote, of concern and consistent with some form of obstruction of her airways, such as smothering. The symptoms of a seizure suggested oxygen deprived to the brain. Child J has not suffered a seizure since. Dr. Evans added, quote, whilst I have concerns, one cannot rule out the presence of infection. Despite the normal inflammatory markers at the time of the two collapse episodes, I note also the presence of the stoma, which could be the source of the organisms that caused her systemic infections, end quote. Dr. Evans, in a follow-up statement, maintained, quote, airway obstruction was the most likely cause of child J's collapse. Dr. Sandy Bowen concluded that the issue was not infection because there were no soft signs and a gradual deterioration which might be expected, but the collapse was sudden and had caused seizures. In interview, Letby said she had little recollection of child J, but remembered the Broviac line. She confirmed contact with child J, but denied doing anything to cause her harm. In 2020, she was asked why she had searched Facebook for child J's parents. She replied, quote, I don't remember doing that. The prosecution said, quote, it is remarkable that on many occasions, when children who had suffered unexpected, spectacular and life-threatening collapses were removed from her orbit, they had exceptional recoveries, end quote. Child K murder allegation. Child K was born at the Countess of Chester Hospital in February 2016. Very premature and weighing only 692 grams. There was not time to deliver at a hospital for this type of maternity delivery. Dr. Ravi Jairam, paediatric consultant, was present at her birth as a result. Lucy Letby booked Child K onto the neonatal unit. Child K had required help with breathing, but was stable and in as good a condition as a baby of that prematurity could be. Arrangements were made for Child K to transfer her to Arrow Park Hospital. At 3:50 a.m, Dr. Jairam was standing at the nurse's station compiling his notes. Although he did not have a view into Nursery 1, Dr. Jairam was aware that the designated nurse was not there, a fact backed up by door swipe data. Lucy Letby was the only nurse in room 1, alone with Child K. Quote, feeling uncomfortable with this because he was beginning to notice the coincidence between the unexplained deaths and the serious collapses and the presence of Lucy Letby, Dr. Jairam decided to check on where Lucy Letby was and where Child K was. As he walked in, he could see Letby standing over Child K's incubator. He could see Child K's oxygen levels were falling. However, the alarm was not sounding and Lucy Letby was making no effort to help. Dr. Jairam went straight to treat Child K and found her chest was not moving. He asked Letby if anything had happened, to which she replied, quote, she just started deteriorating now. Dr. Jairam found Child K's breathing tube had been dislodged. Child K was very premature and had been sedated and inactive. The tube had been secured by tape and attached to Child K's headgear. Mr. Johnson, quote, it's well recognised if you handle a child you can dislodge the tube accidentally, but any experienced staff member would recognise that. Dr. Jairam was troubled as the levels were falling and Nurse Letby had been the only person in the room. The prosecution added, quote, on these monitors all readings are set to default values in a neonatal unit. Saturation levels falling to the 80s is a serious issue, and if the machine is working properly it would sound an alarm. There is an alarm pause button on the screen of the monitor. If you want to treat the child, you don't want the alarm going away. It will pause for 1 minute. Bearing in mind the rate displayed on the monitor, Dr. Jairam estimates the tube would have been dislodged between 30 to 60 seconds, and that is on the assumption the alarm had been cancelled once. The court hears Dr. Jairam did not make a contemporaneous note of his suspicions or the alarm failing to activate. Child K remained unwell and later died. Medical expert Dr. Evans viewed Lucy Letby's failure to summon help as soon as possible was unusual. The prosecution alleged that Lucy Letby was trying to kill Child K when Dr. Jairam walked in. In police interview, when Dr. Jairam's account was put to her, she said no concerns had been raised at the time. She said the alarm had not sounded. She said Child K was sedated and had not been moving around. She also did not recall either any significant fall in saturations or there being no alarm. She accepted that in the circumstances described by Dr. Jayram, she would have expected the alarm to have sounded. She denied dislodging the tube and said she would have summoned help had Dr. Jayram not arrived, saying she was, quote, possibly waiting to see if she self-corrected. We don't normally intervene straight away if they weren't dangerously low, end quote. After the interviews, that suggestion made by Lucy Letby was referred to a nursing expert. Her view was that it was very unlikely that a nurse would leave the bedside of an intubated neonate unless they were very confident that the ET tube was correctly located and secure. The baby was inactive, and then they would only be away only briefly. The nurse dismissed the idea that a competent nurse would have delayed intervention if there had been a desaturation. Letby was found to have researched child K's parents on Facebook in April 2018, 2 years and 2 months after child K had died. When asked about this, she said she did not recall doing so. The next case concerns twin brothers. Mr. Johnson refers to child L first. Child L attempted murder by insulin. Child L was born in April 2016. It is the prosecution case Letby poisoned child L while also attacking child M, the twin. Child L's blood glucose level was noted to be low and he was treated with a dextrose infusion. His condition improved and he was stable by the daytime shift on April the 9th. Letby came on duty that day at 7:30 a.m. By this time, the prosecution say, Letby was supposed only to be working day shifts because the consultants were concerned about the correlation between her presence and unexpected deaths and life-threatening episodes on the night shifts. In the hours that followed, child L's glucose levels fell abnormally low. He was given additional doses of glucose, but they proved ineffective. The answers to these levels were found after a lab sample sent to the Royal Liverpool Teaching Hospital laboratory came back with results some time later. The results of these tests were, quote, grossly abnormal, but nothing was done about it as child L had, by the time the results came back, returned to normal. The reading was, quote, at the very top of the scale the equipment could measure, the court hears. There was no correspondingly high level of C-peptide. It was within the normal range. The only explanation for this anomaly is that what was being measured was synthetic insulin, which had not been prescribed to child L, but was stored and readily available in the neonatal unit. The court is shown an infusion therapy prescription sheet, a written record of the dextrose bag fed to child L. The bag was running from noon on April the 8th when it had been set up an hour earlier by Letby and another nurse. Prosecutor Nicholas Johnson KC, quote, we say Lucy Letby added insulin to that bag of dextrose. She did it deliberately to kill child L. She had failed to kill child F, so gave an increased dose. Letby had been present for the birth of child L. She cared for him on his first day, and the prosecution say would have been aware of his mild hypoglycemia. Child L's blood sugar level remained dangerously low through the day. At 4:30 p.m, a new infusion bag was required, and this was being applied when child L, the twin brother, was being taken ill. The prosecution says medical expert evidence is this was a case of insulin poisoning, administered intravenously via child L's liquid feed. In police interview, Letby said she was aware of child L's low blood sugar levels and knew that insulin was kept in a locked fridge, with a variety of other drugs. Keys were passed around nursing staff and there was no record of who held the keys at any time. She agreed that insulin could not have been administered accidentally but denied being responsible. Her explanation was it must have been in one of the bags already being received. The prosecution say that is not a credible possibility. Child M was born in good condition and was assessed as requiring special care. He had an unexpected life-threatening event at around 4 p.m. on April the 9th. At the same time, his twin's blood sugar was dangerously low. The prosecution say, quote, he came close to death, but within 4 hours he was able to breathe unsupported. At 3:30 p.m, a fluid bag was attached to child M. At 3:45 p.m, he received intravenous antibiotics. The note showed Letby was one of 2 to administer the medicine. Digital records show Letby's colleague was using the computer at 3:45 p.m. At 4 p.m, child M's monitor alarmed and Letby was first to the cot. The emergency was such that doctors were called urgently. The consultant Dr. J-Ram attended and noticed unusual patches of discoloration on child M's skin, which he thought particularly noticeable because of child M's skin tone. He thought the patches unusual because normally if a baby arrests and there is not enough oxygen moving around the body, the baby is uniformly pale, grey or blue. What he saw he thought similar to what he had seen during the resuscitations of child A and B. Child M did not respond well to resuscitation. 6 doses of adrenaline followed in 25 minutes and treatment was, quote, about to be withdrawn when child M suddenly improved. Dr. J-Ram could not find any cause for the sudden collapse, but the discoloration he saw caused him to suspect an air embolism. At 9:14 p.m, Letby noted child M was tensing his limbs, curling fingers and toes and rotating hands and feet inwards, signs of brain damage. On the following night shift, child M had what the prosecution called, quote, a speedy recovery, although he did suffer further desaturations. Medical expert Dr. Evans said the rapid recovery would not have meant infection or a lung problem was likely. His conclusion was airway obstruction or air embolus. A paediatric neuroradiologist reviewed a brain scan in May 2016 and found brain damage for child M, likely caused by the cardiorespiratory collapse on April the 9th. Mr. Johnson, on behalf of the prosecution, says, when Letby's home was searched in 2018, a handwritten log of drugs administered during child M's collapse was found, and she had made a note of the collapse in her diary, quote, LD, long day, twin resus, end quote. In police interview, Letby agreed she had connected a fluid bag to child M and had co-signed for medication at 3:45 p.m, but could not be sure if she had administered it. She thought she must have taken the notes home, quote, by accident, and had simply noted what had happened in her diary. She denied that the notes were a souvenir, and denied deliberately trying to harm child M. She could think of no reason how he would have suffered an air embolism. The prosecution says the cases of child E to F and child L to M are similar, in that one suffered an insulin overdose and the other an IV air embolism. Mr. Johnson states, quote, we suggest that coincidences like that simply do not happen innocently. Someone was responsible and the only credible candidate is Lucy Letby.